Welcome all of you to this live program at Orthopedic Principles. Today our guest of honor is Professor Pieter Caekebeke from Belgium. Professor Pieter is an orthopedic surgeon specializing in elbow surgery and works at the Ziekenhuis Oost-Limburg in Genk, Belgium. And he's also a visiting professor at the Hasselt University. He graduated in medicine from the University of Leuven and began his orthopedic training at the University of Antwerp in Belgium, and completed his advanced fellowship at the Royal North Shore Hospital in Sydney and also in Antwerp with Roger van Reet. In 2022, he obtained his PhD from the Hasselt University on distal biceps tendon pathology. Professor Caekebeke has published more than 50 peer-reviewed articles and contributed to several book chapters. His research has been present at the leading international meetings, including the CC Congress in Dublin, where he was awarded the Norbert Schwen Prize for his work on distal biceps tendon pathologies. He's a board member of the Belgian Shoulder and Elbow Society and serves on the CC committee and is also a committee member of the Global Elbow Network. So today is my great honor to introduce you, Professor Pieter, for this wonderful live program. Over to you, Prof.
Thank you. Thank you. First of all, thank you so much for inviting me and giving me the opportunity to talk to you all about distal biceps tendon tears. I have no conflict of interest to disclose. And let's start it off with the function of the distal biceps tendon. We all know, of course, that the elbow is a joint that can have a lot of motion, but the biceps tendon specifically, or the muscle, is in function of elbow flexion together with the brachialis muscle, and most of all, it's responsible for forearm supination. If you look at the anatomy, and it will be important to understand it later on, we know there's a long head and there's a short head of the distal biceps tendon. The insertion point of those two is a little bit different. So we have quite a long insertion of the short head, more distal than the long head, and the long head is a little bit more posterior. And why does it matter? It matters because this position allows a short head to allow for more flexion than the long head. So it's the most important flexor in all rotations. And the short head is the most important supinator and in neutral and in pronation. But when you go to complete supination, due to the posterior position of the long head, we have an increased force of the long head for supination force. We all know, or this is what was taught historically, that it arises a rupture of the distal bicep tendon in about 1.2 to 2.5 in 100,000. It's more often with middle-aged men and more current in the dominant arm than in the not dominant arm. It used to be said that it occurs due to a flexion force or an extension force, a sudden extension force on the flexed arm, but we know due to video analysis that it's mostly due to an eccentric load on an extended arm in supination. And if you look at this video, if it works decently online, you see that it's mostly occurring in for instance, deadlift, because there's a quite extensive eccentric load on an eccentric arm. And my idea around it is that you actually have a sort of peel-off maneuver of the distal biceps tendon of the bone, because the angulation is very sharp and the forces cannot withhold it. Compared to what we used to think, we know that there's an increase of the incidence of distal biceps tendon. And this is, for instance, a Swedish registry, but we saw that indeed in 1997, when the incidence was determined, there was a surgery in about 1.3 in 100,000. But in 2016, it's almost 10 in 100,000. And the ruptures do the same increase. So either we had less recognition of the ruptures in older days, or it just occurs more. If we want to diagnose a distal biceps rupture, there's a whole bunch of different tests that we can do. And the most famous, of course, is the hook test that has been described by Sean O'Driscoll, and where we try to hook the biceps tendon from the lateral side. So you try to hang your coat off it. And you have to do it on the lateral side, because on the medial side, we have the large surface of the distal biceps, and that may confound you. We can have resisted flexion, resisted supination. If there's weakness, you can do a variation of the Thompson test of the Achilles tendon, a sort of squeeze test, and You see a supination maneuver if you squeeze it, but a very important one is also an increase of the distal biceps crease interval. That means the distance between the interval, or the crease of the elbow and the muscle belly, as you can see in the above pictures. And a study that compared all different tests saw that not only was the hook test not as proficient as we thought, that we more often need a multiple test to have a certain diagnosis. So a Dutch study looked at it in a very large series, and we saw that if you combine the hook test together with the biceps crease interval, that you're almost certain that you have a distal biceps rupture. If only one is positive or they're both negative, we might have to consider imaging. Looking at the imaging, you would consider, of course, to do an ultrasound. It's mostly for the patient because, like I said before, if the biceps crease interval test and the hook test is positive, we're almost certain that there's a rupture. Then we don't really need an ultrasound. Furthermore, it's very operator dependent, but in complete ruptures, previous studies have shown that it's as good as an MRI. So if you're really in doubt and you suspect a complete rupture, you can consider ultrasound. It gets a little bit more difficult if we talk about incomplete ruptures. So if we look at partial ruptures or bursitis or tendinosis, because then the patient will still have an intact hook test. Ultrasound and MRI may not be as conclusive, and there's some pain and some weakness. So in light of my PhD, we evaluated that. But first, we need to make sure that it's not an isolated short-haired rupture. So as you know, there's two tendons, like I told before, the short head or the long head. You might encounter a complete rupture of one of the heads. And which head will it be? It will be the most distal one, again, because it's a peel-off. In my mind, it peels off, but you have two separated tendons and only one is completely ruptured. The problem with this instance is that, of course, the hook test, you will still be able to hook something, but it's not a partial rupture because one of the head is completely ruptured. I come back on the investigations later on, and in those investigations, we can differentiate between a complete isolated short-head rupture or a partial rupture. If we look at the clinical investigation of partial ruptures, for my PhD, we developed a new test, and this is the biceps provocation test. And basically what you do is you ask the patient to perform a resistant flexion of the elbow, first with the arm in supination and then in pronation. It's very important that you resist the flexion on the forearm and not on the wrist. Why? Because, of course, if you do it on the wrist, that might be also positive in, for instance, lateral epicondylitis. So we only want to test elbow flexion. Like I said before, the brachialis is the most important flexor. So why does it work? Well, you can see it there on these images who are drawn by the son of Roger van Riet, a very talented drawer. You see that in supination, the torn part of the tendon that is against the bone is turned away from the bone. So if you pull on it, there won't be much pain. While in pronation, actually the tendon wraps around the radius, and that torn part is squashed against the radius, and therefore it elicits pain. If you look at it via endoscopy, you can see it here clearly on the left, on the bottom. You see that you see the torn part because the tendon is turned away from the bone, while in pronation, it's the other way around. If we're still in doubt, we might consider imaging, and you can do an ultrasound and an MRI. We covered ultrasound already, but ultrasound for partial rupture is not as good as for a complete rupture. And the problem is, of course, that the torn part of the tendon is below the intact tendon against the bone, so you can't really see it. So we looked at MRI, because of course that's something that might come in handy. And we saw that MRI is very good for complete ruptures, but is less proficient for partial ruptures. Therefore, a new position in the MRI was developed, and it's called the flexion abduction supination view, the FABS view. And as you can see, this is how the patient is installed. And on the right, the advantage is that in this position, we see the complete tendon in one slice. So it's much easier, or so it's thought, to evaluate possible tendon tears. For my PhD, we evaluated it, the FAPS view against standard MRIs for biceps pathology. And what we actually saw, to our surprise, to be honest, is that the sensitivity and the specificity of the standard MRI is as good as a FAPS view. But the FAPS view is more proficient in not to see if there's a rupture, but to see how big the rupture is. So if you don't have access to FAPS view or a position, standard MRI gives you the opportunity to also see the biceps rupture. Let's go over to treatment. And as we are in partial ruptures, we're going to continue in partial ruptures. Partial ruptures, you can treat conservatively. There's different treatment methods that have been described. For instance, rest, you can take medication, physiotherapy, injection therapy. Bauer in 2018 described a failure of conservative policy in about 55%. So only 45% were treated adequately with conservative treatment. We just finished a study that has been published in the Journal of Shoulder and Elbow, where we compared the different ones because that was lacking. And so we wanted to know, is there a difference between a wait and see policy, dedicated physiotherapy, and possible injection therapy with cortisone? Very important, we do an ultrasounded or ultrasound guided injection, because Denise Eigenaal from Holland clearly showed that if you don't do it ultrasound guided, then it's a hit and miss, and it's about 50% of people miss the bursa where we have to inject the product. Overall success rate is in line with the results of Bauer. So we see a success rate of about 50% injection group and 46% physiotherapy and wait and see. Of course, there was a big difference between the time to symptom relief. Clearly logical, if you do an injection, if it works straight away. While with physiotherapy, it's around 3 months, and wait and see around 4 months. So what our line of treatment is for the patients, we tell them, look, they're all about the same results, about 50%. We prefer to do an injection because it works straight away. If it doesn't work, we might have to do something else. What we also saw in this study is that there were no negative effects to possible later treatment by doing an injection, and we didn't see tears that prolonged, because you might be scared due to the product that the tear may get worse, but that wasn't the case. If the patient still complains, so if the conservative treatment didn't work, we have a few options for partial ruptures. We can do either endoscopy or we can do an open reinsertion. Endoscopy has the distinct advantage, they give you a clear view of the torn tendon. As you can see in the right image, the top is the bone and the bottom is the tendon. It's very nice to bring into view. It has a magnified view, and because you don't have to look under the tendon, you don't tear theoretically on the tendon, so you preserve the blood supply, and you have less risk that you would tear it completely off. There's a few things that we can see. We can see the insertion, tuberosities, osteophytes, and the borders. For some reason, the film is not going fluently, but you can see the complete tendon. And what we looked at is if the arthroscopic treatment was as safe as an open treatment, because of course it's a relatively new concept. It's been around since 2010, but we still needed to know. So in 2020, we looked at a cadaveric study to evaluate the safety of endoscopy. And we mainly looked at the distances of vascular and neurological structures, of course. We saw that there's a very short distance to vascular structures, a little bit longer to the median nerve and to the PIN on the anterior side. But as the distances were around about 10 millimeters, it's still advised to do even endoscopy with retractors and not just put in the scope blindly. How it works, you make a small incision, you have different treatment options. I do a single incision arthroscopy or endoscopy, where I make a 2 centimeter, 1 to 2 centimeter incision, and then we place a scope inside. Once we're inside, we have to treat the tear. And historically, it was divided in 3 sort of tears. You have small tears, medium tears, and large tears. For small tears, our idea was that the rest of the tendon was still intact enough so we could do a debridement, while in medium tear, we had to reinforce it with an anchor. And finally, if the tear was too big, above 50%, we would advise a disinsertion and formal reinsertion with a classical bone button. Again, I think my videos work really slow due to the live streaming. But in small tears, we just do a debridement with shaver. It's important to always keep the shaver into view because, of course, it's very close to all these dangerous structures, so you have to be very careful. I'm gonna skip the videos because they don't seem to work very well. So after a while, I was wondering, but what about the results? Because we could do this, and the results, as you will see later on, were not always that encouraging. So I looked up in literature, and that's actually for partial ruptures. I'm not talking about endoscopy for complete rupture, but for partial ruptures, there's not much information out there. There's a study that evaluated a repair with suture anchors versus an endo button, but that's more on the fixation technique than clearly on the endoscopy itself. So I can't give you the big numbers from literature. We can give you my numbers. So if we looked at debridement, about 2 out of 15 remained painful and had to have a complete reinsertion. But the most important lesson that they take ages to heal. So it's about 8 months before they get pain-free, which is about the same amount of time that we need in anchor fixation. So then the question remains, is this really something, or is it just natural history? Like I told you before with the conservative treatment in physiotherapy and wait and see, it was more than 4 months before we had an effect. So in my mind, this is the same for this. I don't think we do much better than natural history. If we do a complete disinsertion and reinsertion, however, we have the classical results that we'll talk about a little bit later in complete ruptures, and these work very well. So in my mind, there's no really much benefit to do an endoscopic treatment of partial ruptures, and I stopped doing them and now just do a deinsertion and reinsertion. On to complete ruptures, of course. Complete ruptures occur more commonly than partial ruptures. And we know that if we do a conservative treatment, there's reduced power, there's less supination force and less flexion force, but it's mainly a problem of endurance or repetitive supination. And for instance, using a screwdriver are really bad. And we know that the problems of conservative treatment are worse than surgery. Furthermore, it's much easier to treat it if you're doing it acutely than to wait and see and then have to treat it later on. If you look at the outcomes of surgical technique, they're good. Whatever technique, and we're going to go over the techniques a little bit later on, the results of treatment with the surgical fixation is actually very good. But there's also some complications, and the complications differ a little bit depending on which technique you're using. So there's 2 big schools, so to say. You have the school that say we're going to do a single incision, so 1 incision on the anterior side of the elbow, and we're going to retrieve the tendon via there and do a formal refixation. Or you have the more classical double incision where we make a small incision on the anterior side to take the tendon, and then a second posterior incision to retrieve the tendon and fix it to the bone. What we see is that there's a risk of nerve in the major complication, risk of nerve damage, which is about similar between the 2. Same for re-rupture, but we see a clear difference between the minor complications. So in single incision treatments, we see more LACN paresthesia, while heterotopic ossification is a little bit more prominent in double incision, but we'll go over that in a second. When we look at reasons for reoperation, it's mainly heterotopic ossification and the classical deep infection that are the reasons. Re-rupture also occur, but they're mainly dependent on the fixation type. So if we look at heterotopic ossification, then we need to know what heterotopic ossification is. So it's a bone formation, and there's still a lot of debate why it is. In my mind, it's mainly due in this instance because of the bone that come loose via drilling or potential damage due to periosteum. And it's also thought to be very or relatively rare in 1 to 2% of cases. However, we did a study where we looked at all the patients that we did the distal biceps, and we saw some form of heterotopic ossification in about 47%, which is much more than the literature reports. Why is this? This is probably because not all of the heterotopic ossifications, and we're sure of that, have some clinical effect, and we don't tend to do X-rays when there's no damage or no limitation to movement. A Dutch study by Warner looked at the difference between the classical indomethacin that was historically given and normal NSAID meloxicam, and they didn't see any difference between the two. So what we now conclude is that it's probably important to give an NSAID, but it doesn't really matter which one. And we do advise to do a very thorough lavage and hemostasis, so there's not enough or not residual bone formation that can occur. When we do an incision, we do an incision about 2 to 3 centimeters distal to the elbow crease. If you do a single incision, which I use, and it's about 2 to 3 centimeters long. Sometimes we have to adapt our incision based on the configuration of the patient, but it's almost always the same. Historically, in literature, you will find that the incision is around 2 centimeters from the elbow crease. Why do we do 3? It's because of the recurrent branch of the radial artery. We know that it crosses about 2 centimeters distal to the crease over that tendon. So if you're gonna do an incision there, then you may risk to damage it. You have to either ligate it or do serious work to prevent bleeding. So what we prefer is to take a little bit of a distal incision and do our movement upwards. So we look up at the tendon from distally and we go underneath the blood vessel. And if you see this image on the right, which is a clinical image, so where the arrow points, that's where the recurrent artery is. So I don't have to touch it and I can work distally on the distal biceps tendon. A problem for the single incision is, like I said, is mostly temporary neuropraxia of the lateral antebrachiocutaneous nerve. And this is a problem, in my mind, mainly of us trying to make the smallest incision possible. Wherever you see people doing smaller and smaller and smaller incisions. And we know that the smaller incision, the more we have to retract. So the neuropraxia probably occurs due to enough tension or traction on that nerve. So I think it's important that you don't do a massive incision, but big enough so you don't have too excessive traction on that nerve. Secondly, to prevent, for instance, neuropraxia of the superficial branch of the radial nerve, which is here on the right side, we have to remember that the biceps tendon is a part of the flexor compartment. So we can't go overly under the extensors because there's where the superficial branch of the radial nerve lies, and that's what we want to prevent damaging. Once we decided, and this is very important, I don't try to propagate either single or double incision. I think it's most important to do what you're used to, because if you do always the same, you have less risk of damaging structure that you don't want to damage. So in my mind, if you're used to single or double, use what you're used to. Once we have our incision, we also need to do our fixation. And there's different types of fixation that have been described. For instance, anchors or bone tunnels. We have a bicortical button described by Bain, and the possible addition of an interference screw. For me, it's all about immediate rehab. So I like my distal biceps tendons to be able to move straight away. The patients are much happier. If you look at the sort of patients that have distal biceps ruptures, they don't want to sit still. They worked for ages to gain massive biceps muscles. So if you put them still for 3 to 4 weeks, they lose a lot of muscle mass, and they don't want that. I'm not saying they can load straight away, but I want the strongest fixation possible. And if you look at biomechanical studies, we all know that the bicortical button offers the strongest fixation. It allows immediate immobilization and has a lower re-rupture rate than, for instance, suture anchors. A second advantage of the bicortical button, as you see here, is that the tendon, due to its linkage to the button, is placed intraosseous. So it's pulled inside the bone. And that is important because in every fixation of the tendon on wires, there might be some slippage of the tendon over the wires. If, of course, the tendon is in the bone, you have about a centimeter that it can slip away and it doesn't come outside of the bone. While if you fix it on the bone, there might be a risk that the tendon slips away from the bone and there's less adequate healing. And it was shown by the group of Adam Watts and by Sethi in the Journal of Shoulder and Elbow that might be a risk. The disadvantage of a bicortical button is that if we would drill, as you can see in the red line, bicortically from the anatomic position of the tendon, we run the risk of drilling inside or onto the posterior interosseous nerve, which of course is a big disaster. So that's why Bain, when he developed the technique, opted for a non-anatomical placement. So instead of drilling from the anatomic insertion point of the tendon, we're going to drill from a more non-anatomical, and we stay away from the PIN. Even then, and when we looked at our cadaveric study, the distance on average is about 6 millimeters. If you know that the button is 12, that's very close by. This is how it looks clinically. You see how close that button is still to the posterior interosseous nerve. Therefore, there's some tricks and tips that you can provide. One is we suggest, or they suggest in this study by Lutringer, to do the drilling with the arm in complete supination, because then, of course, the PIN turns away from the point where you have to drill. The more proximal you drill in the tuberosity, the safer it is, or the more distance you create from the PIN. And if you don't want to drill too high, of course, to risk the neck, you can also drill towards the proximal side. So the more proximal you drill in orientation, the safer, which of course is in line with the more proximal position of the drill in the previous slide. There is, however, a disadvantage, by drilling it non-anatomically, because we don't return the strength as it was before. And that is a reason we drill through the tuberosity where the tendon is attached. Not only are we going to have a less posterior position of the tendon, which of course is important for the supination force, we also gonna drill through the cam of the tuberosity that you see in the red circle, and that is a protuberation. So there's a little mountain, and the tendon is wrapped around it, and it's a sort of cam effect which increases the power. As we drill through it, of course, there's less supination force in the end. They used to suggest to use an interference screw on the radial side to push the tendon really to the ulnar side. And this idea was the more in the posterior, the ulnar side we place it, the more supination strength we get. However, we did a segmentation study on patients who were treated with both bioabsorbable interference screws and peak interference screws, and we looked at the hole that remained. we saw that in patients who had a peak screw, as you see on the right table, you have about 38% of widening. In biabsorbent screws, 44%. While if you only use the bicortical button, we had a closure of the tunnel. The top picture shows this very well. This is a peak screw. You see the big hole that's in the radius. That's, of course, a theoretical risk of fracture of the proximal radius because you have a big hole in the middle of your bone. So for us, we never use an interference screw because of this risk. In light of my PhD, we started to think, what can we do to improve or make this technique safe, but with the advantages of the bicortical button? And first of all, we thought maybe we just have to place that button inside of the bone. So unicortically, it would be possible to do it anatomically. The nerve would be safe. Gap formation, we didn't really know. But when we tested it, we saw that one button on the tuberosity is much weaker than the bicortical button. And that's what we don't want. We want a strong fixation to have an early rehab. So for us, ideally, and that is debatable, but for me, the single incision would be the way to go. We need a strong fixation, an anatomical position. It needs to be safe for the neurological structures. And we want a position of the tendon inside the bone to prevent gap formation. So we started with a CT analysis of the tuberosity, and we see that the tuberosity is very weak on the stop point, and we have to span the whole tuberosity to have a thick cortex on which we can purchase our intramedical button. So based on this study we did on 144 CT scans, we developed a curved button that we could insert inside the bone. And here you see how it looks inside. So the tendon is attached to the button. The advantage is we only have to drill unicortically, so it's safe for the nerve. We can do it anatomically because, again, the nerve is safe. And the tendon is still pulled inside because due to the position and the bell shape of the tunnel, it's pulled inside the bone for about, in average, 7 millimeters. But of course, we needed to know whether it was strong enough or not. So we did a biomechanical evaluation. We evaluated stress and strain. And more importantly, we saw that it was as strong as a bicortical button. We didn't want it to be stronger. It would be awesome, but it's fine to have the same strength as a bicortical button because we know that works very, very, very well. If you look at the motor failure, we see in the unicortical fixation, we had bone failure and 5 tendon failures, while in the bicortical, we have 3 tendon failures and 2 bone failures and 1 wire. So it's about similar. Based on these biomechanical studies, we did some in vivo testing on patients. So we did 10 consecutive distal biceps repairs. And first, we did it non-anatomically. And the reason is, if it would really break out, because it was never tested, we could still drill through and do a bicortical fixation in that way. And then once after that, we did 11 repairs in an anatomical fashion. Again, the video is probably a little bit too slow, but you all can look it online. We can share the link to it later. But what we saw, if we looked at the results, is that the range of motion for the non-anatomical fixation is about the same as in literature. So full flexion supination at 2 weeks, extension a little bit slower, and pronation takes about 3 months. If you look at the anatomical, we see full pronation only at 6 months, and this is logical because you place the tendon more posterior and it takes more effort to do a complete pronation. Looking at strength, non-anatomically was the same as in literature, so about 86% of the uninjured side. So this is what we see in the classical bicortical fixation. While in the anatomical fixation, we saw a return of complete supination strength. So that's very encouraging. When we look at the radiographic results, we see that there's no fracture of the cortex, there's no cortical thinning, there's no breakout and no migration, and we see actually a closing of the tunnel around the tendon at 6 months on the CT scan, which is of course what we want because we don't want a big hole that might risk the radius from fracturing. Position-wise, you see on the left anatomic, we drilled through that cam, and while on the anatomic side, we went way more posterior, and the cam effect is remained, so the supination strength is restored. Complication-wise, we had about 40% of transient lateral anterior cutaneous nerve neuropraxia. We have some heterotopic ossification, but they were asymptomatic. And of course, we didn't have any PAN lesions because we did a unicortical fixation. I'm very happy to say that we now found a firm that is manufacturing these, and we hope to bring them out somewhere in Q1, Q2 of 2026. Thank you so much.
Thank you, Peter. Peter, you can stop sharing.
Yes. Stop share. Thank you.
Thank you, Peter, for this very comprehensive presentation on distal biceps. Since it was your PhD thesis, I'm sure you're a master of this.
Well, I'm not going to say that, but we've done a few.
Great. Peter, let's have a short Q&A. Now,
Mhm.
Peter, there's a lot of interest since you mentioned endoscopy in one of the slides. There's a lot of interest among surgeons on the role of endoscopy, right? So it is pretty early with respect to endoscopy, right? It's only for debridement and say partial ruptures. Can you explain to the audience well? Because we have viewers from different parts of the world.
Yeah. So for partial ruptures, I think it's not often used. We tried it, and like I said, the results were not very encouraging. So I think the most interest is on endoscopic treatment for complete ruptures, like Professor Bhatia from India, done massive, great work. It's possible, it's feasible, it's doable. The question for me is where lies the advantage? I think in acute ruptures that you can easily pull away through a small incision and only make a 2-3 centimeter incision, that's not a big advantage. What I do think the advantage may lie in, but I don't have enough experience. But what I see from Professor Batia's work is in chronic ones, when you have to look at the tendon really up there in the arm, then you don't have to do a big incision to retrieve it. So that might be an advantage. But like I said, I haven't gotten around to it because for me, if you do a more difficult technique like endoscopy, you need a clear benefit, and I don't see the benefit as of yet.
Thank you, Peter. And the other one was you use the bicortical button, right?
Mhm.
That's your preferred. And when do you start mobilizing it? Do you think early mobilization is critical?
Day one. So
Day one.
I do a lot of them on their local regional. So they get a sling for day one because their arm sleeps for about 7 to 10 hours. But after that, they can move. So I send them free and I say you can lift up to 20 kilos. And those people, they really look for it to do it. So that for me is a big advantage because I don't trust a lot of people, but especially the distal biceps guys, I don't trust them, and they all want to move. So if you want to keep them still, they're not going to stay still, and that's why I like a bicortical button because it offers strength.
And do you think there could be a difference if you're using an interference screw with respect to early mobilization?
No, I don't think when we looked at the strength or the force, there's not a big increase of force during interference screw. And like I said in the presentation, interference screws may have some osteolysis, so it actually poses a risk for me. So I never use an interference screw.
And Peter, see, when we do an ACL surgery, ACL reconstruction for the knee, what we look is the isometric point, right? We look at 30 degrees of flexion. That is where when we tighten the screws.
Mhm.
So what about the elbow? What is the right position where you need to get so that it is not too lax, not too tight? How do you get the tension right?
Well, in an acute rupture, it's pretty easy, especially with the bicortical button. You suture it to the button and you pull it through, so it's massive strength. In more chronic cases, and especially if you do reconstruction, is difficult. So if I do a reconstruction, I want them about 90 to 70 degrees because they always stretch out. But that being said, look at it the other way. If the tendon retracts, the arm will not be able to extend. That's more important. but we're not afraid of that. I'm happy to reinsert it with the arm 90 degrees, but they always loosen in the end. So for the elbow, it's not that important to have the tension right. It's more that we often over tension them because they're shortened by the chronicity of the injury.
And in these chronic ruptures, have you in any situation had to use a graft so that because your tendon wasn't coming down and you had to bridge it with the graft?
Yeah. So, like I said, for me, the reasons to use a graft is that if there's no tendon, and you quite often see them in patients, big bodybuilders who inject a lot, that tendon is not quality, so you pull them out of the muscle, or is it too short? If I don't have a tendon for at least 2 to 3 centimeters to put sutures in, then I will use a graft. If I still have a tendon, I don't care if I have to suture it all the way here, that will stretch out. But I need something to put my sutures in to put the button on.
And what would be your preferred graft?
For me, I use the Adam Watts technique, which is Achilles tendon. And so basically what you do is you have the Achilles tendon and you put 2 strands
Allograft,
with
allograft, right?
allograft, yeah, and you do pulvertaft, and then the rest is a wraparound. But I have to admit, it's lucky for us because we have a bone bank, so I always have grafts, which is easy. If not, you can do either palmaris or you can do even around the knee semitendinosus, and you can do a sort of sling from the muscle to the
I think
insert.
hamstrings would make sense, right? Because
Yeah.
it's stronger one, thicker one.
Yeah, and they have
Uh,
less problem with it than an Achilles autograft. That's not very accepted, I
I
think.
think great. Peter, thank you so much. I think that has been a spectacular presentation and great answers, and we really look for more in future. Absolutely stunning research work that you do in Belgium.
Thank you so much. Thank you for the invitation.